If we look then at the continuum of care of chemotherapy throughout many lines of chemotherapy in metastatic gastric cancer, we currently have fairly standard established approaches. First-line chemotherapy, we need to know HER2 status. For most patients, we would combine a fluorinated pyrimidine with a platinum agent with or without trastuzumab based on the HER2 status. That would be standard first-line chemotherapy. In patients progressing on first-line chemotherapy, standard second-line treatment would be paclitaxel plus ramucirumab. Third line, then we would have to factor in PD-L1 status or MSI status. We could consider third-line irinotecan-based treatment, which would be an option. If a patient is PD-L1 positive, we have approval of pembrolizumab as a salvage option in chemotherapy refractory disease. If a patient is MSI high, there's even a stronger enthusiasm to use pembrolizumab given the high response rate and durable responses. In a PD-L1 negative patient, we would have to consider conventional chemotherapy or referral for a clinical trial, given the low degree of efficacy of anti-PD-1 drugs in that population and the fact that we don't have regulatory approval for those patients.
With the advent of personalized medicine, where we're able to really look at the molecular profiling of the tumor, we get an immense amount of understanding of the biology of the disease and the tumor, and helps us then pave the way of choosing the next lines and the lines of therapy that you would use for those patients. The NCCN has really gone over very nicely the different regimens to be used. We already know that triplet regimens like the DCF and ECF in the metastatic setting can be far too toxic with minimal improvement in survival and response rate. So if we were to look at some of the doublet regimens, which we're all very familiar and are comfortable treating with, which include FOLFOX, FOLFIRI, cisplatin irinotecan, docetaxel irinotecan, or then incorporating some of the targeted drugs like paclitaxel with ramucirumab, which is a VEGF targeted drug, or using a HER2 targeted drug trastuzumab in combination with the chemotherapy in the first line setting, and then not moving forward in the second and third because we have limited data for that. And then as we go through the multiple lines of therapies, patients who have been pre-treated with chemotherapy and are known to have an MSI high tumor or PD-L1 overexpressing tumors would then benefit with pembrolizumab or immunotherapy drugs such as that.
Important in treating a patient with metastatic esophageal gastric cancer is treating the symptoms, treating the nutrition-related issues. These are often patients that present with swallowing problems, early satiety, poor oral intake. Because chemotherapy has responses in about 40 to 50% of patients, these symptoms often become better with initial treatment. Key other issues aside from nutritional support would be adequate pain management, psychosocial support, counseling, and even psychiatric support to manage things like depression and family interactions. Nutritional support typically would be potentially an enteral feeding tube if it's absolutely needed. TPN or total parenteral nutrition we really frown on because that's fraught with lots of complications and typically not something we would do in most patients. Because chemotherapy has a benefit fairly early on, symptoms often improve. If patients have obstructing esophageal tumors that can't be stented, we might sometimes think about an enteral feeding tube. That can be complicated in the management of gastric cancer. If they have ascites and carcinomatosis, they might not benefit from such an approach. But that's also where the multidisciplinary management comes in, having a good gastroenterologist on board, a pain management team, psychosocial support, psychiatry, if need be.
Whenever I see a patient with advanced or metastatic gastric cancer, I always have a very clear discussion about the goals of care. So patients who have unresectable metastatic locally advanced cancers, the goal of care is palliative care, which is to improve their symptoms, improve their quality of life while prolonging their survival. So establishing that upfront paves the way for a really good relationship through the course. And you're able to help the patient immensely and the family to cope with and really achieve what they want to in their limited period of time. And we do that with the team, which is the pain and palliative team. We team up with the integrative department, which includes getting Reiki and yoga. We've extended the yoga, which is a free complimentary yoga for our patients, to caregivers, because they're the ones who bring the patients in, take care of the patients, change their whole lifestyle so that they could then continue to help their family member who's sick get through the treatments.